Now I call upon Dr. Ronnie George, sir, for speaking on surgery in angle closure disease, when to do and which one, trabeculectomy versus combined phacotrabeculectomy.
Good evening, and thank you, Dr. Meena, for making me part of this IC. So when we look at angle closure disease, these are all the various ways they're present. You can have all the types that were mentioned earlier, and also the acute primary angle closure, and you can have plateau in any of these coexisting with any of these conditions. So I'm going to discuss what the available evidence is in each stage of angle closure and the risks and benefits potentially in different stages. So when you look at the progression of primary angle closure suspects, and this has already been presented, 22% progressed over 5 years. And in the Mongolia study by Paul Foster, 20% progressed at 5 years. The risk of progression to PAC from PACS is low, and which is why we don't recommend anything except in high-risk cases. And therefore, for PACS who has undergone YAG LPI and on follow-up and has developed cataract, if the angle opened up post-LPI, you can do cataract surgery whenever you do it routinely. If the angle did not open up post-YAG-PI, do it a little earlier because that will help with the angle. In somebody who's an angle closure suspect without a YAG-PI in place, maybe earlier cataract extraction could be considered. But keep in mind that there should be a cataract. Coming to the glaucomas now, when you look at the primary phacoemulsification and IOL implantation for acute angle closure glaucoma, this was a terminology at that time, but this is today called acute primary angle closure. There was this non-randomized comparative trial which looked at lens extraction versus surgical iridectomy as a treatment, primary treatment for this. And what they found was the phaco group required fewer medications, 0.1 versus 0.45 between the groups. But in both groups, you had patients requiring between 0 to 2 medications at the final follow-up. Additional surgery was necessary in 5 eyes in the phaco group and in 20 eyes in the iridectomy group. But once you reanalyze this by excluding the patients who required only cataract surgery in the iridectomy group, there was no difference between the two groups. So we know that post-acute angle closure cataract does progress a little bit more rapidly. And what was also interesting here was that 7% of these eyes had a capsular tear or vitreous hemorrhage, vitreous loss. This wasn't a large case series, so fortunately there was no expulsive hemorrhage or something like that. So in these hot eyes, going and unnecessarily removing a cataract is not a great idea. But typically with an acute angle closure, which is resolved post-laser iridectomy, you probably don't need to do anything very aggressive. But what if you have medically uncontrolled PACG? So there is this, there are 2 papers which have compared trabeculectomy in medically uncontrolled chronic angle closure glaucoma with cataracts versus phaco alone. And these are eyes which had at least 180 degrees of cynical closure. So you can see the IOPs were about 24. They were on more than 3 drugs each. They had close to 270 degrees of cynical closure. They had fairly significant visual field damage, minus 17 and minus 18 decibels. And about 1/4 of the eyes in both groups had a history of acute primary angle closure. So when you look at the intraocular pressure, definitely IOP levels were better in the phacotrabeculectomy group. The number of drugs required post-op was also better in the phacotrabeculectomy group. Over time, within these 2 groups, in the phaco group, 4 patients out of the 25, which is again about 15 to 20%, required trabeculectomy, while in the combined phaco-trab group, no patients required additional medications at 12 months after surgery. So in patients with chronic angle closure or primary angle closure glaucoma with uncontrolled IOP, phacotrabeculectomy seemed to do better than phaco alone. What about if you had medically controlled PACG? So you have medically controlled PACG. What about trab versus phaco-trab? And this is again with 180 degrees of cynical closure, very similar results. So here you have 3 groups. The top is the medical group, who had only phaco. The bottom is the phaco-trab group, and the middle is the phaco-trab group with the hypotonic cases removed. So they had 7 patients in this group who had hypotony. The number of drugs required post-op was again lower in the phaco-trab group. So in the phaco alone group, 14% progressed at 2 years. In the combined phaco-trab group, 16% progressed at 2 years. So there were really no differences in progression between the 2 groups. But keep in mind that when you did a phaco-trab, In these patients who are controlled medically, you will end up with significant hypotony. 7 out of 35, which is in 20% of people. So patients medically controlled with PSCG, you're probably better off just doing the cataract alone. Now, primary angle closure to primary angle closure glaucoma, this slide has also been shared before, about 28% progress over 5 years. And we say that all eyes with PSC should undergo a LPI. So here again, you have two situations. You have PSCS with PSC or raised IOP, or you have PSCS without Sine K, but with raised IOP. They're all going to have a YAG PI, that's protocol. And in that situation, you'll land up with a group which has narrow angles post LPI, and you'll land up with a group which has open angles post LPI. So if you have open angles post LPI, there's really no rationale to go in and take out the lens. You can probably manage with a trabeculectomy alone. But if you have open angles post LPI and uncontrolled intraocular pressure in this situation, you would consider doing a trab and a cataract surgery, because that is what seems to work even in PSCG. What if you're controlled with intraocular pressure on 2 drugs? So if you have open angles post LPI, I would consider only cataract surgery. If you have narrow angles post LPI, again I would consider only cataract surgery if they are controlled on 2 drugs. The exclusion to the rule is if you have extensive Sine K with narrow angles post LPI, in that case I might consider adding on a trabeculectomy, because these eyes you can sometimes cause the angle to decompensate after surgery, especially if you're on more than 2 drugs. So keep in mind, when you have more than 2 drugs, you follow the rules very, very similar to open angle glaucoma. You combine it with a trabeculectomy when you think it is necessary. What if you have PSCG with uncontrolled IOP and cataract post LPI? I think the evidence is fairly clear that if you have open angles, definitely trab plus cataract surgery. And if you have PSCG with controlled IOP with 2 drugs and cataract post LPI, only cataract surgery unless you have very advanced visual field damage. So when you're on more than 2 drugs with PSCG, what do you do? So I'm going PSCG and PSC. So this is PSCG now. In this situation, not controlled on 3 drugs, definite damage on the visual field, you definitely need to do combined surgery in both groups. There's really little role for you to do cataract alone. Keep in mind that accommodation is an important function. So if you have an open angle and a controlled IOP post-op and an uncontrolled IOP post-op, post-laser, you can probably just go ahead with only a trab in those eyes. And keep in mind also that cataract extraction is not without complications. It's higher with angle closure, and angle closure, an acute attack or an eye with a very high IOP, you're more likely to run into trouble on table. And not all apposition opens up after surgery. So just doing a cataract surgery, when you can still land up with residual apposition, and this is something that you should keep in mind, because even these patients require occasional gonioscopy. There are some exceptions to the rule. If there is a history of aqueous misdirection in the fellow eye, I would always prefer to combine with a cataract extraction, even if the cataract is very early, because becomes easier to manage these eyes. If the angles are open post-iridectomy, but you have a very convex iris, there's a high lens vault, there's very little buffer for the AC to shallow if you do a trab alone. So combine with a cataract surgery, even if your IOPs are okay. So to summarize, you have multiple situations. With PSCS, you have a lower threshold for cataract. With PSC, with residual angle closure post-PI and uncontrolled intraocular pressure, instead of doing a trab alone, combine with a cataract surgery. With PSC with open angles post-LPI, if your pressures are controlled, you can go ahead with a trab alone, but you have a lower threshold for a cataract. Acute primary angle closure, the best option is probably deferred cataract surgery. Consider doing a trab alone if you're struggling to control it. PSCG with residual angle closure post-PI and uncontrolled intraocular pressure, definitely combine your trab with a cataract surgery. And PSCG with open angles post-LPI and uncontrolled IOP, if you're on 2 drugs, do only a trab. If you're 2+ drugs, maybe a slightly lower threshold for cataract surgery. So thank you, and I hope that answers some of your questions. I haven't spoken about mix because he's going to talk about it, but in some of those situations it will be useful.